Good morning, class. Today, euthanasia is being debated, and I'd like to present some interesting and convincing evidence that proves euthanasia should either be banned or that the system should be improved at the least. My opponent presented 3 points. Letting a terminally ill patient continue to suffer from unmanageable pain is inhumane. 2, the problem is that people don't have access to pain relief, and for the solvency, my opponent proposes that the nation must adopt the Oregon model, which is the Death with Dignity Act. Although these points seem accurate, my partner and I would disagree. First, I'll address the first point that it's inhumane to let a terminally ill patient continue to suffer from unmanageable pain. First off, claiming that all terminally ill patients suffer from unmanageable pain is simply untrue. Medical director of the Mayo Clinic and also medical doctor Roger Harms states that only 1 in 3 patients undergoing treatment for cancer experience cancer pain. And that's coming from a medical doctor working in a hospital. Through palliative care, it has been shown that pain rates decrease once treated with proper hospice care. Surveys suggest that most people want to die at home and that 50% of them don't. Through the Oregon model, most patients end up dying in a hospital. My opponent's inherency claim reads as follows. The problem is that people don't have access to pain relief. In some cases, this must be true. What I think my opponent is trying to pinpoint relates to pain management as it relates to painkillers, so I'll focus on that. Nationwide in 2010, pharmacies dispensed the equivalent of 69 tons of pure oxycodone. Painkillers are not the only form of pain management, yet apparently seem to use up a lot of the country's money as treatment. My opponent's point seems a bit unclear because although it may be hard to find the right form of pain management, it's also hard to deny the sheer amounts of painkillers being pushed on patients. If more money were being used to fund preventative care and palliative care, the need for pain management wouldn't be necessary. That's why rather than adhering to a euthanasia model, more money should be spent on preventative care because more people would ultimately end their lives more content. Also, accessibility of proper pain management is not an issue. Over at the International Covenant on Economic, Social, and Cultural Rights has held that states must make available and accessible in sufficient quantity functioning public health and healthcare facilities, goods and services, as well as programs, because they believe that every human has the right to the enjoyment of the highest attainable standard of physical and mental health. Finally, moving on to my opponent's solvency claim that we should adopt the Oregon model. The Oregon model has many flaws, and my partner and I believe that the Death with Dignity Act should be improved before being implemented. As reported by the New York Times in April 2010 and written by Marilyn Golden, there is a case of 2 different people whose chemotherapy wouldn't be paid for under the Act, but their physician-assisted suicide would be. Why? An Oregon administrator explains that the state can't cover everything for everyone. I don't know about you, but if I ever somehow got into that situation, I wouldn't want to die just yet. Another flaw is that even though the Act clearly states that each physician-assisted suicide is successfully carried out be reported to the state, yet the Oregon Health Division has no authority to enforce reporting requirement. The Act also clearly states that patients pass several mental and physical tests to qualify for physician-assisted suicide. Yet, in May of 2004, Michael P. Freeland of Portland was prescribed lethal drugs for physician-assisted suicide, even when he had a past of attempted suicides and a medical record of severe depression. This just proves that even though the safeguards on the Act are put in place, they're not being followed. All these reasons support the banning or heavy regulation of PAS in America.